I suppose there'll be many people coming from different perspectives to the talk and from different areas of expertise, and I suppose that's both the benefit and the risk in these webinars, is that, you know, I suppose, you know, beforehand we would often maybe have an idea as to where, you know, which audience in particular that you were targeting about a talk, whereas, you know, it's brilliant now that we have this opportunity to really talk about a concept that up until a few years ago, brain health wasn't really something that anybody was discussing, and really the prevention of dementia as a concept is something that's quite new as well. So I'm going to try and just set the scene for Emer and Marianne's talks later on, and then just also happy to, you know, evolve any of these points for discussion later. And I will, you know, much of my presentation is really about, you know, the process that goes on in the brain that, you know, results in dementia. But I'll also try and insert pieces whereby, you know, it's relevant to this specific group of people with intellectual disability and Down syndrome who are at greater risk as well. You know, look, and I suppose step back and take a larger view. I mean, there are about 64,000 people who are currently living with dementia in Ireland. This is a number that's increasing. The majority of those live in the community, and I suppose that's one of those concepts that often people's understanding of dementia is that it is a condition that, you know, has a predefined endpoint where somebody requires institution care. Well, the vast majority of people who live and you know, die in their own homes, thankfully, and in their own communities. I suppose the big thing is that age is the biggest risk factor for dementia, and one of the great successes over the last few years has been how much longer people are living, and this goes for people, you know, who have intellectual disability and people who don't, and that increased lifespan does bring with it that increased risk that more people will be living with dementia. And how we cater to that. And we know that there are probably in around 800 people with Down syndrome living in Ireland with dementia. So it's really essential that we develop much better preventative, diagnostic, therapeutic and social care solutions for people who are living with dementia. I think it's, you know, partly, you know, or, you know, this general, you know, push to develop, you know, broader memory services around the country, but then also it's a key focus in the strategy that Mary and I and colleagues have had in developing the national ID memory service as well. I think when we, you know, think about dementia, you know, probably the most common question I get asked in the clinic is what do I mean by it, and what's the difference between dementia and Alzheimer's disease? I think, you know, dementia is very much an umbrella term and actually not a diagnosis in its own right, and it's really where, as a result of a memory or thinking difficulty, which causes an impairment in somebody's daily activities, and it causes them to not be able to do their day-to-day activities as well as beforehand. So it's not, if you like, oftentimes people are very nervous about the pencil and paper tests that we would do in the clinic and their performance on that. But rather than it's not just about memory. In fact, the key part of a diagnosis about dementia is how somebody is able to perform their day-to-day, you know, activities and that functional loss. Alzheimer's disease is the most common cause of dementia, and we'll elaborate on those a little bit more later on. But the other key causes are stroke, and vascular disease, and Parkinson's related dementia, and a thing called frontotemporal dementia. And as I said, the most common question I get asked is what's the difference between Alzheimer's disease and dementia, and how I often would describe it is that, you know, when we use the term dementia, it's a bit like saying that somebody is short of breath. It doesn't tell you what's causing it, whereas if I say it's asthma, it tells you exactly what's causing somebody short of breath. So similarly, dementia is like saying somebody's short of breath, but Alzheimer's disease is the cause of that memory difficulty that's leading to functional decline. And what we've really, you know, begun to understand and our knowledge of what causes dementia has really expanded over the last decade or so, and we know that around 65% of dementia is caused by Alzheimer's disease, and that's caused by these proteins. And what we've clearly delineated is over the last few years is that there are particular proteins that build up in the brain in Alzheimer's disease, which are a little different to the proteins that build up in the brain in Parkinson's disease, and a little bit different to those ones that build up in the brain in frontotemporal dementia. So we know that these abnormal proteins building up in the brain is what results in those symptoms of dementia. And different proteins result in a different cause of dementia. And we know that amyloid and tau are the name of the proteins that build up in the brain in Alzheimer's disease. Now, it is always possible that people will have 2 or 3 different causes of dementia, and they may have different proteins building up in the brain. But the big and the important message around identifying these proteins is that once we identified them, we were able to start looking at developing medicines that can target these protein accumulations. And we'll talk a little bit about why that's important later on. Of course, there's a specific particular connection between Down syndrome and Alzheimer's disease in that we have 23 pairs of chromosomes, and that's what contains our genetic material. But on people with Down syndrome, they have an extra chromosome 21. And that's also the chromosome which contains genetic material for a thing called the APP gene, which can sometimes increase the production of this protein amyloid that we see in Alzheimer's disease. So people who are living with Down syndrome are at a greater risk of developing Alzheimer's disease as they grow older. Other key risk factor and the other key piece that we see oftentimes alongside Alzheimer's disease, but sometimes in its own right, is what we call vascular dementia, or dementia related to blood vessels. And that almost accounts for about 1 in 5 causes of dementia, and often we find it coexisting with those proteins that we would see in Alzheimer's disease. And this is where somebody may have a blockage of one of the blood vessels in the brain, or a little rupture in one of the blood vessels. So either small little bleeds or small little clots in some parts in little areas of the brain. And those would be key areas that are responsible for memory functions. And this is an example of an MRI scan. So the gray tissue is the brain tissue, and that's all normal tissue, whereas this white is where there's scarring, if you like, on the brain scan related to this, what we'd call vascular dementia or vascular disease. I often, try and describe the brain like a fuse board. Now, this is a very reductive statement, because what we're really understanding about the brain is that it's a series of networks connecting different parts of the brain. But sometimes from a conceptual point of view, it's easier to just understand it as that there are certainly key areas of the brain responsible for key functions. So we know that the frontal lobe, this part of the brain at the front, is very important for problem solving, and it's very important for speech production and things like that. And it's also the part of the brain that controls how we move and is responsible for our movements. The temporal lobe is often the part of the brain that's most impacted by things like Alzheimer's disease. And this is where those proteins build up in the temporal lobe, where we have memory and our information is stored. But it's also the part of the brain that's responsible for comprehension and our ability to process what we hear. The occipital lobe then is our visual lobe. It's where an awful lot of our visual perceptions are organized, and then parietal lobe is our main sensory lobe. So touch and perception are parts of that. And then cerebellum is one of our key motor lobes. It's down at the base of the brain. And for many, many years, it was presumed that it didn't have a role in memory, but now we know that it's very, very important from the point of view of procedural memory, and also emotional memory is a key role of the cerebellum. So different parts of the brain. So depending on where these proteins build up in the brain and which proteins build up in the brain, you may get different symptoms. And that's often one of the common things that I may have to discuss with somebody in the clinic is why their symptoms are different to, let's say, a neighbor's or another relative's, or that somebody else who they knew who was living with dementia. And it's really that, for everybody, their symptoms and onset and where things are at, really depends on which protein is responsible for the dementia and what part of the brain is most affected. And as a result of that, sometimes people will have commonly memory loss for Alzheimer's disease. They may have hallucinations for the protein that builds up in dementia with Lewy bodies, or they may have more inappropriate behavior in something like a frontotemporal dementia, or personality changes, same thing in that frontal lobe. And really the terminology that's evolved over the last 10 or 15 years is this concept of biomarkers. Now, biomarkers are biological markers of a condition that really, defines the condition and establishes definitively that the condition exists. And up until about, certainly up until the last 5 years or so in a clinical context, and up until the last 10 or 15 years in a research context, the only way that we diagnose something like Alzheimer's disease was on the basis of you coming along to a doctor, describing your symptoms, and the doctor saying those symptoms sound like Alzheimer's disease, and it probably is Alzheimer's disease. Now, what we would do in our clinic regularly, especially in the general memory clinic, is we would do a thing like called a lumbar puncture, which is a little needle whereby we take a little bit of spinal fluid and we measure these proteins, amyloid and tau, that are associated with Alzheimer's disease. And what we know is that these proteins can build up in the brain 15 to 25 years before somebody even has memory symptoms related to their memory difficulties, which means that we have this really long period of time where these proteins may be accumulating in the brain, but the person hasn't had significant changes in their brain to cause dementia at that stage. So we may have a really, a good window of opportunity to intervene to reduce the accumulation of these proteins. And that's our great hope when it comes down to, when it comes to trying to, enhance brain health and come up with therapies to minimize the risk of dementia. And of course, what's happening quickly and evolving quickly is also these scans. So a lumbar puncture is a relatively invasive, albeit we do them quite routinely, and they're very well tolerated. It is a relatively invasive procedure compared to just having a scan. And what's evolving very quickly, and in an Irish context, we should be able to do these specialized scans which measure this protein amyloid, which is the main culprit protein associated with Alzheimer's disease. And these are radiation labeled scans, okay, where we put a special tracer onto that protein, which highlights areas of the brain where it's accumulating. So these biomarkers have now really entered mainstream clinical practice. They've been around in research for the last 15 years. We've understood an awful lot of them, more so with Alzheimer's disease than with other causes of dementia. But as a result, now we're able to confirm biologically whether or not somebody has an Alzheimer's disease that's causing their memory difficulties. It's also, by virtue of the fact that we were able to measure these proteins, it has greatly enhanced our understanding of the process, in that when we track forward people to the age of 90, and bear in mind, 1 in 20 people at the age of 65 would be living with dementia, which goes up to about 1 in 5 people at the age of 80, which nearly goes up to 1 in 2 people by the age of 90. What we were able to do in some of the research is look at the protein accumulation in people at the age of 90. And what we found is lots of people, so almost half of all people, have a lot of these Alzheimer's disease proteins in their brains at the age of 90, but many of them don't have dementia. So there must have been a protective effect that is accounting for why some people would have the same amounts of these proteins but wouldn't have a clinical picture of dementia. And that's really where people started looking into, well, what are the protective factors that one group of people have that is minimizing the risk for developing dementia, despite having these proteins in the brain, relative to the other group who did develop dementia. And what we know is there are some things like, that build into our cognitive reserve, such as education and our occupational attainment, and then these key other modifiable risk factors. The other thing that made us quite confident that there was a potential to intervene is when we looked at cohort studies going on over the last 40 to 50 years. And in particular, if we take this very well-known study called the Framingham Heart Study over in Boston in the United States, and they've been following up people for over 40 or 50 years. And what we know is that over the last 40 years, the age-adjusted risk for somebody to develop dementia has reduced by more than 40%. And the mean age at onset for dementia, so the mean age at which people were developing symptoms, has gone up by 5 years. And just that in its own right, pushing out the age of onset of symptoms has a dramatic effect in the reduction of people living with symptoms of dementia. And when they started looking across other cohort studies, they found very similar results in the United Kingdom and Sweden and Netherlands, where they would have dementia registers. And it's largely due to better blood pressure control, better treatment of diabetes, and better cholesterol management in midlife in particular, that has led to this dramatic reduction. Now, it's important to say that the overall incidence of dementia is going up and up because we have far more people living into later life and living to greater years. So the lifespan of people is going up exponentially. So we have there's far more people who are living with dementia overall, but one's age related or age adjusted risk for developing dementia is less. So as an 81-year-old, I'm 41% less likely to develop dementia today than an 81-year-old back in the 60s and 70s when they were doing this initial cohort. And, the Lancet Commission, which is probably our highest order of evidence, recently updated their own publication from 2017 into 2020, which came with a really strong statement that said up to 40% of dementia is potentially preventable. And they broke it down into, there's some risk factors such as our age, our genetics, and our gender, which at the moment, they're not modifiable. But then there is this huge number of risk factors such as hearing loss and high blood pressure and diabetes. And I won't go through them all because I know Emer and Marianne are going to be talking about them. But these huge collection of risk factors which we can modify and which we can intervene with. And actually, I think also what was really helpful is they showed that these risk factors aren't the same throughout the life course, that there are risk factors in our midlife that are important that we target, such as hearing loss, which is often overlooked and has turned out to be a very, very important and very significant risk factor. And that, moderate hearing loss in midlife is almost as big a risk factor as our genetic risk factor for developing Alzheimer's disease. And then these other risk factors such as smoking and depression and social isolation in later life. So there are risk factors that have greater importance at different stages of life, and that can be targeted at different stages of life. I'm just going to finish up by summarizing. I mean, we've really tried to bring this piece into both our general and into the ID memory service here in Tala, whereby we have a particular focus on our post-diagnostic and support service. So there is the post-diagnostic clinic, which will often try and talk and support people through a diagnosis of dementia, and do a care as education and support group, but then also to do a targeted brain health piece. And I suppose what we really do is we focus in around people who have, in particular, milder memory symptoms. There's probably less evidence for significant interventions for people with more significant memory symptoms, but we really try and intervene around those group of people who are worried about their memory or who have early signs of memory symptoms. And I'm happy to go through and answer questions afterwards.
Thank you very much, Professor Kennelly. That was just amazing, no matter how many times I hear some of these issues. It always triggers so many things that we can and should be doing. So thank you very much for that. I'm going to leave the questions to the end, and we have a number of questions that have come in. And I'm just going to go ahead and introduce our next speakers. So I want to introduce our next speakers is Dr. Emer McGlinchey. And Emer is Assistant Professor in Intellectual Disability at the School of Nursing and the Trinity Centre for Ageing and ID at Trinity. And she's also a Senior Atlantic Fellow for Equity in Brain Health at the Global Brain Health Institute at Trinity. And Emer's main areas of interest has been around dementia prevention in people with Down syndrome. And she actually did her PhD on that many years ago. So it's wonderful to see Emer continuing in this area. And she's principal investigator now of the Prevent Dementia Down Syndrome project, which she'll talk a little bit about, looking at early biomarkers. So that's Emer. And I also want to introduce, this is a joint presentation, Marianne Fallon. And Marianne has come with extensive experience around dementia in people with intellectual disability. She's a chartered health psychologist with almost 20 years of clinical experience in working with this population. And Marianne is currently working with us in the National ID Memory Clinic as the Education and Training Officer. And she's also doing her PhD at the moment in developing a biopsychosocial model of cognitive decline in people aging with an intellectual disability. And our third panel member is Mei-Lin Yap. And we're delighted to have Mei-Lin Yap join us this morning. She's our Ambassador Liaison Officer in the Trinity Centre for Ageing and ID in the National Memory Clinic. And she works with us in really representing the work that we're doing and building support around public patient involvement. And she's a regular contributor to many publications, including the Frontline magazine and their social media pages. And she is a permanent employee of CPL Recruitment Agency, where she's a senior HR assistant. I'm going to hand over now to the team, and I think it's Dr. Eamon McGlinchey perhaps that will take over now. Thank you.
Thanks so much, Mary. And so I'll just start. I know Sean has already gone through this, so we'll just mention it very briefly. Again, in the relationship between Alzheimer's disease, dementia and Down syndrome. So as Sean mentioned, people with Down syndrome have a genetic predisposition to Alzheimer's disease, and this is because of 3 copies of chromosome 21, where it's this chromosome that produces the amyloid precursor protein gene. And so there's an overexpression of this gene and overproduction of the protein. And this can then lead to amyloid plaques, where that's the hallmark, one of the hallmarks of Alzheimer's disease. And so we know that nearly everyone with Down syndrome will have this neuropathology, these brain changes of Alzheimer's disease by the age of 40, but that not everyone will go on to develop symptoms of Alzheimer's disease. And it's that difference between the two that is really important. So in just thinking about that, at the minute, we don't currently have a way to stop this disease progression, to stop these plaques forming that lead to Alzheimer's disease. But there is a lot of work going on and research going on this at the minute, and people with Down syndrome are now being included in this type of work. So as Mary mentioned, there's a project, Prevent Dementia DS, and this is a project that is looking at early biomarkers of Alzheimer's disease. So this is really trying to see what are the very earliest changes that happen in the disease process. So this might be decades before there are any symptoms. And if we can identify them, can there be treatment that will stop the disease from progressing? But we're not there yet at the minute in relation to preventing that pathology or that disease pathology. But what we do have, as was also mentioned, is really good evidence around things that we can do. So things that we can do as part of our lifestyle and ways that we may be able to prevent or delay these symptoms of dementia. And so this is something that's particularly important for people with Down syndrome because there's this high risk of the disease. So it's more important to make sure that throughout the lifespan, we're promoting brain health, promoting these things where there is evidence that if we address them, it can reduce the risk of developing dementia. And so Marianne Fallon is going to talk about some of these, looking at the biopsychosocial model.
Thank you, Emer, and hello everybody, lovely to be here today. So I suppose we just wanted to get started to get an idea from all of you attending today. What things do you think are important to maintain brain health? And I know Professor Kennelly has mentioned a few, but would you like to share your thoughts with us in the chat box just over the next few seconds? What things can you support people with ID to do to maintain their brain health? And maybe if you could just type into the chat box there, please, when you're ready. Great, there's lots of ideas coming in already. Physical activity, keeping active, social connections, people have loads of ideas. Yeah, absolutely. Social activity with friends is coming up a lot. Healthy diet, regular exercise, lifelong learning. That's great. Yeah, absolutely. So that's really great to hear people's ideas there, and they're very relevant to what we're going to be speaking about now in terms of the biopsychosocial model of brain health. So I'll continue on with that. If we can go to the next slide, please, Emer. So as Professor McCarran mentioned, I'm a health psychologist, and one of the things that I'm interested in is putting brain health into the framework of the biopsychosocial model. And this is a framework that we use in health psychology, and really it's the underpinning model that we use to promote health. So I suppose, you know, years ago, there used to be a very narrow biomedical focus on people's health. So we just looked at the biology of people, chronic conditions, how their body functioned. And now a lot of clinicians of all disciplines are very interested in taking a more holistic view of the person. And I feel that's really, really important, particularly as a clinician working with people with aging with ID and with Down syndrome. It's very important to look at the person's strengths and needs across their life. So we're looking at biological elements, psychological elements, and social elements of their functioning, and trying to see what strengths they have in those areas and what needs they may have, and then advising them at a holistic level how to maintain their brain health as they age. Next slide, please. So just to break down those different elements, the first element is the biological element, and that's really your genes. you know, if you have a chronic illness, how your body is functioning physically, how well you are physically. Suppose the normal idea of what we have, it is to be healthy. That's the biological element of the biopsychosocial model. The second element then is the psychology element. So very important as well, equally important, how we feel on a day-to-day basis, how our mood is. Are we generally depressed? Are we generally anxious? Or are we in a happier frame of mind most of the time? How we think about the things that affect us, how we cope with the daily stresses of life or extra stresses, such as now in this time of COVID. So that's the second element of the biopsychosocial model, the psychological factor. The third element then is the sources of social support in our lives. And again, these are very important. People may have more or less social support. They may be socially isolated, or they may feel very lonely, or indeed they may have a lot of social support in our lives. And this is something I think that is particularly important for people with ID to look at. And a lot of you have mentioned in the chat box that social engagement and having friends and family is important for brain health. Next slide, please. I won't dwell on this, as Professor Kennelly has already gone into detail on this. So basically, I'm going to take some of the elements, a number of the elements from the Lancet Commission report, and place them into a biopsychosocial framework for yourselves today. It's just an easier way to remember how to promote brain health in people aging with ID. Next slide, please. The first section I'm going to look at is the biology of brain health, the physical condition of your body. So the very first thing, and again, Professor Kennelly made a mention of this, and somebody has also asked in the chat box about this link. Hearing loss, it's amazing. It's not something you necessarily think of as adding to your risk of developing dementia, but the Lancet report says it adds 8% of the overall risk of developing dementia, as Professor Kennelly mentioned too. And some of this may be because that as we are less able to hear things in our environment, we're doing less sensory processing of the brain. We're doing less processing of the sensory issues that are coming from outside into our brain. So our brain is getting less of a chance to work out, so to speak. It also means if we're losing our hearing, we may engage less with people in conversation. So again, we're getting less social engagement and our brain is working less hard because we're getting less sensory stimulation. And some emerging American research has actually done MRI scanning on people with hearing loss. And they've found that the hypothalamus, which is one of the memory centers in the brain, very important for memory, that is actually shrinking in people with hearing loss over a long period of time. So they're starting to see there's a definite link between hearing loss and the reason perhaps why there may be some memory loss going along with hearing loss over time. And people attending today may know that people with ID, especially people with Down syndrome, can have a higher risk of hearing loss, particularly as they age. And Dr. McGlinchey will be speaking about the Irish statistics for people aging with ID from the IDS Tilde data on this later. But we know this population has a higher risk in Ireland. There are very low levels of hearing testing based on the IDS Tilde data and low levels of use of hearing aids. Now we know people may not tolerate hearing screening or hearing aids, but we would certainly recommend that for people who can tolerate it, that they will be supported to obtain hearing screening every 3 years and also to wear hearing aids if they will tolerate it. And if they won't tolerate hearing aids, at least if we know that they have a hearing condition, we can support them in other ways, maybe using pictures or speaking more clearly, different accommodations if they don't hear very well. And just to say as well on this, clinically, I have found that people themselves and their carers, supporters, may not be very good at picking up on hearing loss. This may be because the person already has maybe different levels of ability or they're masking their hearing loss. But often I would ask if the person has a hearing loss. Now the person or the supporters may feel they have, but then on testing, it's often found they do have a hearing loss. So just to reiterate that point, it's really important to try to support the person, encourage them to go for a hearing test. Next slide, please. Again, this leads back to what Professor Kennelly mentioned, and there was a question in the chat box around this. The link between cardiovascular disease and diabetes from the Lancet Commission report and the development of dementia. And as part of my PhD research, I'm looking at this again in a very general sense. There's emerging research now that metabolic health is very important long-term for your overall physical health and also for your brain health. So poor metabolic health can consist of having high blood pressure outside of the normal range, having abnormal cholesterol levels, so having high levels of bad cholesterol LDL, and having low levels of good cholesterol, HDL. Also having excess fat around the waist and having high blood sugar levels. Over time, these different factors can lead to low-level chronic inflammation in your body. And clinicians will score, if you have 3 out of these 5 factors, is that you have metabolic syndrome. And this metabolic syndrome over time, with this chronic low-level inflammation of bodily systems, can lead to cardiovascular disease and type 2 diabetes. And we know that as you age, having cardiovascular disease and type 2 diabetes are big risk factors for developing dementia. So looking at somebody's metabolic health and supporting them to keep good metabolic health and keep them within normal parameters is very important. Next slide, please. So how do we do this? Some of this, again, in the biological factor in terms of promoting brain health is looking at our health behaviors. So people can be supported to eat a Mediterranean diet. And again, research is strong. This is good for your overall physical health and for your brain health. And the Mediterranean diet is generally plant-based, fruit, vegetables, whole grains, nuts, seeds, healthy fats such as olive oil for cooking, and things like avocados, and lots of fish, very good for your brain. Moderate dairy intake, which is, reasonable levels of cheese, yogurt, and milk, and then limited meat intake, more plant and fish-based than meat. And one way that I would always say to encourage people with ID to understand about having a healthy diet is encourage them to eat all the colors of the rainbow, because we know that processed food, it's often quite bland in color, it's starchy, it's fatty, whereas vegetables and fruits, nuts, seeds, they're all very colorful. When you go into the supermarket, you see a whole range of colorful fruit and veg. That's always really appealing to your eye. So it's important to encourage people to try to eat well and eat the colors of the rainbow. Next slide, please. Also, another very important health behavior to promote metabolic health is at least 30 minutes of physical activity 5 days a week is recommended. And again, people mention this in the chat box. Any activity counts. I often hear from people that the person they support isn't interested in exercise, doesn't like going for a walk. And I would say any activity, if you can, do any activity, even around the house. Are they interested in gardening? Are they interested in doing some housework, even going up and down the stairs, doing laundry, any of those things that people can do that are useful for their activity, it all counts. Or taking part in fun activities with friends and family. Again, building activity into everyday life. We all know that if you start a new physical activity, it won't necessarily work if you don't enjoy it. So you've got to find something the person enjoys and encourage them to take part in that. Next slide, please. Sleep, again, is another very important health behavior you mightn't necessarily think of, but it is very important for brain health, and more research is showing this. And we know that people with Down syndrome particularly can suffer from sleep apnea, which is disrupted sleep during the night due to a difficulty with breathing. So people may wake up gasping, or they may snore a lot, or they may have very disrupted sleep. So again, that's something to check if there's any suspicion of that. Or people may just have poor sleep. So support a good sleep routine. The usual advice, relax before bed, get rid of the electronic devices, and 7 to 8 hours sleep needed per night, because our brains need that restorative sleep to clean down the toxins from the day, to reset our brains, to process our memories from the day, and we wake then refreshed the next morning. Next slide, please. Usual advice, it's not so much an issue with the older people that we support, but if people are smoking, help them stop smoking and only drink within safe limits, and people are familiar with those guidelines. Next slide, please. So then that's the biology section for brain health. But I suppose something that's equally important, and again shown by the Lancet report, is the psychology of brain health. And we'll move on to that now, please. So depression has been identified as a big risk factor for developing dementia. It increases the overall risk of developing dementia by a large percentage. And depression can arise for people we support with ID from stressful or upsetting life events, from poor quality of life or chronic illness, from medication side effects, or indeed some people are just genetically predisposed to their brain chemistry to be more inclined to develop depression. So again, this is a big risk for dementia, so we really need to ensure depression is treated. Milder cases of depression can be supported by lifestyle interventions such as access to counselling, more physical activity, more choice and control in a person's life, more social engagement, anything like that, a better, healthier lifestyle and health behaviours. Or the person with more severe cases of depression may need to be supported to access their GP or psychiatrist. But the main thing is, don't leave it untreated. Next slide, please. The other side of the psychology of brain health is sometimes forgotten, but it's really, really as important. And again, research is starting to show that subjective well-being is a good protective factor for your brain health, promoting happiness. And I won't even try to pronounce this gentleman's name, the Hungarian psychologist. He developed the concept of flow in 1990. And that is when you are really engaged in a task. And we all have hobbies or activities or work where we're working away at it and we're really engaged and enjoying the activity. And half an hour is gone in the blink of an eye because we are being challenged by our brain. We are managing to do something that we're finding a little bit difficult, but we're really enjoying it. And it's sparking creativity and well-being for us. And I think that's really important to look at for the people we support. Even people who can only concentrate for a few minutes or can't tolerate much, there's always something people really enjoy taking part in. And you want to find something that gets the person into a state of flow, that kind of sweet spot there in the diagram between it being too hard and people being frustrated, and it being too easy and people getting bored. So be challenged, but not frustrated. We really need to support the people aging with ID that we support to have activities every day that they can get into the flow of. So thank you, Emer. Next slide, please. So that is the psychology of brain health. And then finally, the last section here is the social factors for brain health. And again, these are really, really important, as important again for people's brain health. And the Lancet Commission mentions that social isolation is a big risk factor for cognitive decline. So social isolation, we look at as being the objective experience of social connection, so that you may have a large number of people in your social network, or you may be fairly socially isolated. Then the feeling lonely piece, you may feel lonely even if you seem to have many people in your social network. It's more of a subjective experience. So we need to check with people themselves that we support. Do you feel lonely? Would you like to know more people? It's very important to check in. And staying socially connected is very important. And people again mentioned this in the chat box. Having meaningful social roles, big or small. Again, people can be very present in community in a large way through work or lifelong learning, or some people may be more home-based and they can still have roles in their house, maybe collecting the post or going into their day service with bringing in doing some small jobs there, or being present in their community with tiny towns in non-COVID times, or trying to be present in their community with restrictions at present online. And we really have to seek out ways for people to be present in their community. And in the next webinar on cognitive stimulation therapy, our colleagues will be speaking about ways to keep socially connected in these restricted COVID times, being connected online. So that again is another very important part of brain health. So I suppose this brief overview today is just to help people to understand the three elements of promoting brain health: the biological elements, the psychological elements, and the social elements. And now I'm going to pass you back to my colleague, Dr. McGlinchey, for more.
Thanks so much, Marianne. And I'm just going to talk about some of these factors that are highlighted in the Lancet Commission and that Marianne has highlighted, and some of the data we have from Ireland around these. So this data is from the IDS Tilda study, where the IDS Tilda study is a longitudinal study including people over the age of 40 with an intellectual disability in Ireland. And so this study has been going on now for more than 10 years. So every 3 years, we go back, we ask the same people the same questions, and then we can see what changes as people are aging. And we're also then able to compare this to the general population. So when we look at some of these issues, we can see that there are some areas where there's a much bigger disparity between what we see in people with an intellectual disability than what we see in the general population. So for me, I think one of these biggest differences is around education. And so for people with an intellectual disability, we found that 32% had no education and 51% had some primary education, but that just 3% had secondary level education or higher. This is very different to the general population, where we had 43% had secondary education and a further 34% had higher education. Now, again, bearing in mind with all of these data that this is including people who are age 40 and over. So the picture might look different now for people who are in their 20s and their 30s. Hearing loss, as Marianne mentioned, it was 10%. There was 10% hearing loss in the overall intellectual disability population, but that this was higher for people with Down syndrome. If we look at then other physical measures, the biological measures that Marianne has spoken about, hypertension or high blood pressure is lower in people with an intellectual disability than in the general population, and that screening for high blood pressure was really high with this population. So that's something that's positive. Similarly, levels of alcohol and smoking were lower for people with an intellectual disability, and diabetes was quite similar for people with an intellectual disability and the general population. I think the other areas where we see quite a big difference, if we look at physical inactivity here, so 85% of people with an intellectual disability were underactive. And that compared to 39% for people in the general population who reported low physical activity. And again, we see that maybe reflected here within levels of obesity. So there was 43% of people with ID were obese compared to 33% in the general population. So high for both groups. But if we combine these, so 79% of people with an intellectual disability are overweight or obese. So I think in looking at this data, it gives us an indication. This is data from at a population level. So when we're looking at data from people throughout the country, so I think it can give us an indication of some of the areas, and these are areas that are modifiable that we may need to particularly target or particularly look at ways that we can intervene or support people with an intellectual disability, because we know these are important for brain health. But as I said, this is population data, but it's also really important to look at individual and each individual as in and look at how we can make interventions for people as they come to the memory service. So within the National Intellectual Disability Memory Service, there's supports and services across the continuum of brain health. So from information and brain health check through to assessment, diagnosis, and post-diagnostic support. So I'm just going to talk initially about these first stages, the information and the brain health check. So you might have seen from previous webinars that we've developed a number of accessible materials related to brain health, and these can all be downloaded from our website. And these are, again, talking about ways based on the Lancet Commission and looking at things holistically from a biopsychosocial perspective of things that people can do to support their brain health and to empower people to take control over their own brain health. We're also then in the National ID Memory Service, so could do a brain health check, and this is a baseline screening for people to understand where people are at before there is any level of cognitive decline or any kind of change. And this is also an important time to be able to talk about brain health and to promote brain health. And within the memory assessment and support services, this is the memory service in the general population that Professor Kennelly is director of in Tallaght University Hospital. The advanced nurse practitioners, Kathy McHale and Josh Dookie, have developed this personal prevention plan. And so this is where it's individualized. So to look at all these different aspects as highlighted in the Lancet Commission and that Marianne has highlighted, and to see what areas of a person's life may need to be adjusted or that certain areas could be promoted, so that each individual plan will be different and will be tailored specifically to the person. And so we'll do this also in the National ID Memory Service. This will be adapted where the plan will be accessible, and we'll work with the person really to empower the person again to take control of their own brain health and to identify areas of life where adjustment or changes might be made. I think one of the most important messages around this is that it's never too early and it's never too late. So I think the best time to start talking about brain health or start thinking about ways in which we can promote brain health is always now. I just want to mention briefly two studies that sometimes the issue of cognitive training often comes up when we talk about brain health. And this study was done a number of years ago with people with Down syndrome. It's called the BEAD study, so brain exercises for adults with Down syndrome. And this was really a feasibility study, first of all, to see if doing cognitive training, computerized cognitive training, so on an iPad, is feasible with people with an intellectual disability, because this hadn't been done before, hadn't been written about before. So I suppose one of the most important messages was that it was certainly feasible. It was a small enough sample. There were 40 people with Down syndrome included in the study. But overall, people enjoyed the program. The program was doing cognitive training for 20 minutes a day, 5 days a week over 8 weeks. And so overall, people completed the program and enjoyed the program. We also then wanted to see if doing cognitive training has an effect on levels of executive function. So executive function are things like memory and planning and levels of attention and that kind of thing. So we first measured these, so had different memory assessments, attention assessments at the start, and then people did the 8 weeks of cognitive training and then measured again at the end. And we also had another group who didn't complete the cognitive training yet. And so while the sample was quite small, the results were encouraging in that following the training, there seemed to be an improvement in some of the memory assessments and attention assessments following the training. The program that was used in this particular study actually doesn't seem to be available anymore, but there's another one that's very similar called Happy Neuron. And there was another study done, including people with an intellectual disability, that used CogniFit. That is also used in the general population, and there's good evidence base for that as well. Finally, then, I just want to mention 2 initiatives that we're doing as part of the National Intellectual Disability Memory Service and the Trinity Centre for Ageing and Intellectual Disability. And this is with Dr. Andrew Allen as well. And so one of these is called Building Bridges, and we're collaborating on this with the Global Brain Health Institute, the ARC in San Francisco, and Down Syndrome Ireland. And this is where we're connecting people with Down syndrome in Ireland with people in San Francisco over tea breaks, where we have a number of tea breaks, and we talk about brain health, or see what things are people currently doing to promote their brain health, and can people share tips with each other. We're also have developed the Brain Buzzers Club, and this is starting this week. And I want to particularly thank Kalina Connors from Down Syndrome Ireland for all her support with this. And again, this is a club where we'll learn about brain health, we'll talk about brain health, and give people the opportunity to share tips and to really start the conversation. And people in the club will also act in an advisory role to some of the research that we're doing within the National ID Memory Service. So just hand back to Marianne now, just to finish up.
Thank you, Emer. That's great. Yeah, just very briefly to finish up. Again, our very positive message from all 3 speakers so far today has been that it is possible to keep your brain healthy as you age. It is possible for us all to support people aging with ID once we remember the biological, psychological, and social elements of brain health. And I suppose the other message is to have fun. Make it to be fun. It should be an enjoyable activity for people aging with ID to keep their brain healthy. Thank you.
Okay, thank you very much, Marianne. I'm not sure if people can see me there. Yeah, okay. Thank you very much, and to Professor Kennelly and Dr. Emer McGlinchey and Marianne. I think that was just a huge amount of information. These slides and this presentation is recorded, so people will be able to access them. I'm going to now introduce Mei-Lin Yap, and I introduced Mei-Lin earlier on. I have a couple of questions, Mei-Lin, that I would like to talk with you about. And I know Mei-Lin, can we see Mei-Lin? Is Mei-Lin on?
Yes.
Yes, lovely. Thank you very much, Mei-Lin, and lovely to have you join us today. Mei-Lin, I know that you're very committed to promoting the overall concept of brain health. And can you tell us, what do you do to promote brain health for yourself?
Well, when this pandemic started, and when we started to work from home, I built up a routine for myself, which I find very helpful. I discipline myself to stick to a routine. I try to do a workout early in the morning before work, have a shower, have breakfast and shower. I dress appropriately for work and put on my makeup every day. I try to stay healthy and fit and have balanced meals. As I have celiac disease, I stick to a gluten-free diet. I try not to, I'm not to have too many snacks between meals, and I keep an eye on the number of soft drinks that I drink, mainly sticking with water. So I find it hard at times to get up early before work to do my workouts, but I'm always glad I made the effort when I have done it. The workouts that I do, examples are Joe Wicks, Paula B Fitness, Body Project, and Zumba classes, and so on. I have a YouTube account where I access all of my workouts. After work, I enjoy going for walks with my dog, Murphy, every day. I try to go to bed relatively early to ensure that I am properly rested and to face an active day. Outside of my working hours, I help at home with everyday chores. My mom and I do online shopping for the bulk of the shopping. I like helping with the cooking, cleaning the house, baking, and gardening. On the weekend, I sometimes enjoy watching Netflix.
Excellent, Maylin. God, what a busy and active life, Maylin. I think we should all, as some commenters come in to say, we should all take a page out of your book, Maylin, and get up in the morning and get Joe Wicks and whoever else on to do a workout. I mean, really, but very practical ways, I think, during lockdown that you have organized your life and developed such structure. Now, one of the big things, Maylin, that we often talk about is, and particularly during the pandemic, and Marianne and Sean and Emer have talked about the importance of social connectedness. And how do we keep connected with your friends and families when we can't meet at the moment? And how did you manage this, Maylin?
Well, firstly, I work for CPL Recruitment Agency as a senior HR assistant. So I find staying connected is most important. At CPL, we have a Stay Connected campaign, and I sit on the committee. Sometimes my manager organizes virtual lunch dates, which I really enjoy very much. I'm very lucky that my colleagues are extremely supportive. They keep me connected and engaged. We have a health and fitness app that provides fitness workouts, meditations, audiobooks, recipes, step challenges, and much more. Our step challenges, of course, adhere to COVID-19 restrictions. Every payday, we have a Zoom gathering where we all have drinks and chat after work. And it is great fun. Overall, staying connected, having someone to link in with, and encouragement to exercise and stay fit and healthy are the most important supports. I consider myself very lucky to be part of such a supportive workplace. I miss not seeing my siblings, but we chat on WhatsApp, phone calls, as well as video calls. My sister and her husband live in London, so WhatsApp would be our main form of communication. They had a baby recently, my first and only niece, Evie. So we had lots of WhatsApp communication. I miss spending time with my brother and soon-to-be sister-in-law. They both live in Cork now, so I have not seen them in person for almost a year. We have lots of WhatsApp video calls and to catch up. They are getting married in early July. They rescheduled their wedding from last year because they could only have 50 people in attendance. Sadly, now they can only have 25. We are all looking forward to meeting up in person for the wedding. Although it is small, I also keep in touch with my friends through Facebook and on WhatsApp. From time to time, I call them for a video chat. I am noticing more than ever the importance of friendships in and outside of work and the value of family. Having friends, staying connected and feeling included is so important.
Thank you so much, Maylin. Those was absolutely amazing. And thank you so much. I think you have shared with us many things, areas that we can all reflect on in our own lives, and given us many really important and critical messages. And I think you have all given us all a wonderful lesson and great take-home messages and what we should be doing and the importance of technology, but the importance of making that effort to create friendships and to retain those friendships and to work on those. I think we'll all be definitely taking some of those ideas.